Hello, my name is Michael Wallace. I'm the chair of gastroenterology at Sheikh Shahbood Medical City in Abu Dhabi. Welcome everyone to our monthly grand rounds. Tonight we'll be talking about new endoscopic interventions to treat both obesity and gastroesophageal reflux disease. I'm joined today by Dr. Mustafa Shahada, who's our director of our endoscopic anti-reflux program and a specialist here at Sheikh Shahbood. And also by Dr. Mohammed Faraja, the director of our endoscopic bariatric programs here at SSMC, and a consultant gastroenterologist. Tonight, we're going to first give a quick case presentation of a patient who underwent a TIF procedure here at SSMC. I'll follow that with a discussion about endoscopic anti-reflux procedures. Then Dr. Faraja will present recent advances in our endobariatric program here at SSMC. And we'll take question and answer at the end. I'm going to turn it over now to Dr. Shahada to present the first case. And Mustafa, go ahead and unmute your microphone.
Good evening, and thank you for joining us. I will present a case with a 43 years old gentleman. He has been following up in gastroenterology clinic in Sheikh Khalifa Medical City and Sheikh Shahbood Medical City for the last since 2014 for gastroesophageal reflux disease. And since this time, he is on omeprazole 40 milligram BID. Sometimes he's using antacid unrequired. He couldn't decrease his dose of PPI to single daily dose. Usually he needed to have a dose BID. His symptoms is mainly heartburn, which is completely relieved with PPI. However, he has a bleaching and reflux 2 to 3 times per week, usually at night. He is very compliant with GERD instruction. He's non-smoker. He has no alcohol intake and not frequent user of non-steroidal anti-inflammatory. He does not take large meal or even and separate his dinner from sleeping by 4 or 5 hours. Upper GI endoscopy in 2018 showed L1 hiatus hernia. This gentleman also has a history of recurrent paroxysmal palpitation, and he has ablation for ectopic focus 20 years ago. But he is not in regular medication from cardiac point of view. He attended the clinic in June 2021 for further management for his long-term GERD. His main concern at this time is the long-term medication side effect because he's more than 5 years taking 40 milligram daily of proton pump inhibitors, and he's well educated and know about the long-term effect with this dose. And even with this medication, he's still having regurg and reflux symptoms. So he was planned for upper GI endoscopy and pH capsule, wireless pH capsule, and this showed antral gastritis and L1 hiatus hernia, and we found that the patient developed 2 gastric polyps, which found to be funded gland polyps. So here's a retroflexion showed the small hiatus hernia for this patient. The funded gland polyp are not shown here, and we deployed the pH capsule 5 centimeters above the Z-line. This is also a picture for the hiatus hernia, the small hiatus hernia, and it is very important here to define the Hell grade, to define the best intervention management for the reflux disease. Then he had a pH capsule result, and this is showed. I don't know if you can see small numbers, but her Dermstell score in day 1, which was off PPI, was 230. And the normal is 14.7, then second day 276, then improved to 240, then 141 in the third and fourth day. So he has really true pathologic reflux. And also he has 100% symptom reflux symptom index regarding the heartburn, and also he has a typical GERD symptom, which is chest pain with 100% reflux associated. So when he has an acid, he also develops chest pain. And he has also another symptom, which is bleaching. To continue with the workup for gastroesophageal reflux disease in case of planning for intervention, we want just to make sure that the esophageal motility are in the right way. So we had the esophageal manometry and motility study and found to have the IRB less than 20, so has a good relaxation in the lower esophageal sphincter, no achalasia, distal latency more than 4.5. There is no premature, and DCI are normal. He has no esophageal spasm, and he has 20% ineffective swallow, so still have a good contraction in the esophagus, and has no major motility disorder. Esophagogram showed small hiatus hernia as seen in the upper GI endoscopy, and usually this is included in the pre-procedure workup. This is not necessary for every patient, but this patient have gastric emptying study, which should be done if the patient have long-term diabetes or symptom of early satiety or nausea or vomiting or any suspicion of delayed gastric emptying if you are planning to go for endoscopic management for GERD. And it was normal. So patient was planned to have transoral incisionless fundoplication, and it was done in 15 of July 2021. Device was introduced with the gastroscope, and 20 fasteners was deployed at 4 area at 7, at 11, and 1, 5, and 7 o'clock to create a valve or to correct the valve, which is 3 centimeter with 270-degree circumferential. And this procedure done under GA. And patient admitted overnight for observation. He had required moderate analgesia for lower retrosternal pain and discharged next day. He had follow-up after 2 or 3 weeks, and he was doing remarkably well. He has no reflux symptoms, and he is able to bleach any gas and slowly advanced to diet. And then another follow-up in November 2021. He was doing very well and required no PPI, only some antacid at night. Thank you.
Mustafa, thank you very much for that presentation. We'll continue now. If Dr. Mustafa will take his, stop sharing his screen, then we'll go ahead and give an overview of new treatment options for endoscopic reflux disease. As you can see, this patient underwent a TIF procedure. This is one of the new endoscopic interventions. We'll talk about this and a couple of others as well. So first of all, as we increasingly perform procedures that were traditionally done by surgery, we need to remember the importance of anatomy and the principles of anti-reflux surgery. We have a long history of success with anti-reflux surgery, and so we don't need to reinvent the wheel. We want to learn what we can from anti-reflux surgery and try to mimic those good outcomes with a non-surgical procedure. The graphic of the lower GI anatomy is shown right here. As you come down the esophagus, you have the usual circular and longitudinal muscles, and then at the gastroesophageal junction, we have the longitudinal muscles that extend and become the distal esophageal circular muscle fibers that cross at the angle of His to form the sling fibers of the stomach. Together with the diaphragm, shown on the right here, these form the lower esophageal sphincter. So our goal is to both tighten the lower esophagus, and also, as I'll show you on the next couple of slides, to recreate the flat valve, which is also very anatomically important. Well, why should we do this? We have PPIs. PPIs are good therapy. However, we know that a significant proportion of patients, 10 to 40% of patients with reflux, fail to respond symptomatically, either partially or completely, to standard dose proton pump inhibitor. Why is this? There's many different reasons shown here, but a core issue is anatomy. The reason patients develop reflux disease is a failure of the lower esophageal sphincter to perform its natural function. So we want to restore that normal anatomy and function as much as possible. Dr. Shahada nicely pointed out the importance of the Hill grade, and this is especially important with endoscopic interventions because endoscopic interventions currently are most suitable in patients who do not have large hiatal hernias. When we describe this on our endoscopy, we typically use the Hill grade, which has been revisited for endoscopic GERD therapy. So Hill grade 1 is a normal valve. There's an elongated flat valve of 1.5 to 2 centimeters and a sphincter that squeezes tightly around the endoscope when you look in retroflexion. These are excellent candidates for anti-reflux procedures, although this is less common. Obviously, this is a normal valve, so it should be functioning relatively normally. Hill grade 2 is the more common indication for endoscopic anti-reflux procedures. Here you have often a shortening of the flat valve to 1 to 1.5 centimeters and some loosening of the lower esophageal sphincter. So when you retroflex the scope, you can see some respiratory dependent incomplete closure. You see a little gap, as is shown in the upper right corner, between the endoscope and the esophagus. The more severe forms of the valve anatomy, Hill grade 3 and Hill grade 4, are less suitable for standard endoscopic interventions, although some recent evidence suggests you can combine a surgical repair of the hernia with an endoscopic anti-reflux procedure. But if you see a wide open lower esophageal flat valve with no closure whatsoever around the endoscope, that's a Hill grade 3, or there's no flat valve present with a permanently open GE junction and a large hiatal hernia, Hill grade 4, these generally require still surgical repair. So let's turn now to the best evidence we have for PPIs. Now, PPIs do work, but they don't work as well as surgery. This was the quintessential randomized controlled trial done by Dr. Stuart Speckler that randomized patients to medical versus surgical therapy for refractory heartburn. The patients who were randomized to surgery had a long-term 50% or greater improvement in their healthcare related quality of life for GERD of 67%, whereas those receiving standard PPI therapy, it was only 12%, and with PPI therapy plus baclofen, 28%. Adverse events were similar across all groups, and so this study concluded that anti-reflux surgery was superior to medical therapy for refractory heartburn. Why is this? Why does surgery work so well? Well, it restores much of the normal anatomy by both lengthening the flat valve and tightening the lower esophageal sphincter. So if we look on the classic manometry, here you see this high pressure zone in red at the lower esophagus. And notice this is the esophagus that extends below the diaphragm. In GERD, you lose that high pressure zone. In the early forms of endoscopic anti-reflux procedure, you got some strengthening of the lower esophageal sphincter. In the more recent versions, TIF 1.0 and TIF 2.0, you got further tightening of the lower esophageal sphincter, which mimics very closely the effect achieved by a standard Nissen fundoplication. So if we think about traditional surgical principles versus the endoscopic approach, we have on the right laparoscopic fundoplication, the gold standard, and on the left the TIF procedure. So both of them can reduce small hiatal hernias. You can repair, if you combine it with a surgical repair of a larger hiatal hernia, you can actually treat both. Note that this is still a newer therapy and is not as well studied as the classic TIF. Both procedures elongate the intra-abdominal esophagus, and both procedures approximate the tightening of the fundus around the distal esophagus. They recreate the dynamic angle of His, and they restore the distal esophageal high pressure zone. So our goal was with these procedures is to mimic as much as possible the successful results of fundoplication. There's been a long history of GERD endotherapies. They're generally divided into lower esophageal sphincter augmentation, the Stretta device, which is a radiofrequency device, and the transoral incisionless fundoplication, or TIF procedures, of which there's several varieties now, including the one our patient had, the esophagus procedure. The Stretta procedure is shown here. So Stretta really treats the lower esophageal sphincter by a radiofrequency ablation. It's in theory, its goal was to tighten it by causing some scar tissue. Here's the device here. It came on the market more than a decade ago, and more recently has come back on the market with some improved evidence of efficacy. Shown here, we see the ablation zone in the lower esophageal sphincter, and we thought initially that it would tighten this, although more recent evidence suggests that it doesn't tighten it as much as it reduces sensitivity. So in theory, Stretta therapy remodels the musculature of the lower esophageal sphincter and the gastric cardia, but the main effect of the Stretta procedure is actually to reduce sensitivity. And we see that in some of the randomized controlled trials here. So we have 4 randomized controlled trials, multiple cohort studies, and one large prospective registry. So there is improvement with a median follow-up of over 2 years. There's improved quality of life. There's a reduction in heartburn scores. There's PPI stoppage in about 50%, and reduction of erosive esophagitis in about 25%. One of the newer treatments is anti-reflux mucosectomy. So this is what we would typically perform an endoscopic mucosal resection. For example, if someone had an early Barrett's associated high-grade dysplasia. Well, that resection actually causes some reshaping of the lower esophagus. It causes some scarring. As you can see here, the mucosectomy is performed in retroflexion. It causes some scar tissue and also reshapes the angle of His. If you perform it on the greater curvature, it will pull the stomach towards the angle of His and increase that angle, which is therapeutically beneficial. Another anti-reflux procedure is the anti-reflux, or the data for anti-reflux mucosectomy is shown here. This is the one for which we have the least data right now. This was a cohort study of 67 patients with refractory GERD. The results are still short-term, 2 months, and a little bit of 1-year data. And overall, we have some improvement. GERD scores reduced from 9.9 to 5.7. PPIs were stopped in about half of individuals and reduced in another 22%. And those were stable. Those improvements stayed at 1 year. So overall, this looks to be potentially effective. The GERD-X is the one that most closely mimics the procedure we performed in our patient. This is also a plicating device. The main difference is that you cannot reduce or you cannot push the esophagus from the intrathoracic portion into the intra-abdominal. So it does not increase the flat valve effect. It does tighten, and that's shown here. It does tighten the lower esophageal sphincter, but it doesn't lengthen the esophagus into the stomach. So there are some anatomical differences between the GERD-X device and the anti-reflux and the TIF procedure. So you can see a short video clip of the procedure here. You can see this rather loose lower esophageal sphincter. A stiff guide wire is placed. The device is passed through the endoscope here. And you can see that the overtube device is shown independent of the endoscope. Here you can see the jaws opening and the corkscrew traction device pulling the lower esophageal or the cardia tissue into this device. So this is quite appealing in its simplicity. It obviously tightens the lower esophageal and cardia anatomy here. And this is probably a bit easier to perform than the TIF procedure, but it does not, as I said before, lengthen the lower esophagus and recreate the flat valve effect. So we do have some early data. This was data published about 2 years ago now from Dr. Reddy's group in Hyderabad, as well as many other experts around the world. We have significant improvement in the GERD health-related quality of life, predominantly at in the early phase at 3 months, but this was not durable. These patients seemed to relapse, so the data on efficacy at 12 months was not improved. So still some limitations of this device. The TIP procedure or Muse procedure is what we'll talk mostly about and the one performed in our patient. So this is the one that most closely mimics the laparoscopic fundoplication. It both tightens the lower esophageal sphincter and pushes the lower esophagus from the intrathoracic portion into the intra-abdominal portion. You can see the device here, and the reason it can do this is these suction portholes that suction the lower esophagus. And as you're doing the procedure, you push the lower esophagus into the stomach right before applying the plication and then fix it here. So here's a video of the TIF procedure. You can see the overtube device here. It consists of a plicating device on the end that retroflexes. There's a retraction device similar to the Muse device, and also the suction ports that I mentioned. You use a small caliber endoscope through the middle of the overtube device here. When we first pass it through the esophagus, it goes through the tip of the device. Here it has to be very well lubricated. We generally do these under anesthesia support. Once the device is in the stomach, you can pull the endoscope back and separate the tip from the plicating device. Here you can see the retraction device. So we pull the lower esophagus into the plication arm. We then get ready to fire the staples. And then you can literally push the device 1 or 2 centimeters forward with the suction here to again achieve that lengthening effect of the lower esophagus here below the diaphragmatic hiatus. Here's some examples of the procedure. You can see this tightening effect. You get a full 270-degree effective tightening. And as you can see, we push the lower esophagus. You can appreciate in the upper right corner the effect on lengthening the flat bowel function. There are now multiple large trials, including the randomized control trial, the sham RCT, and 2 other randomized controlled trials. All of them show significant overall improvement in health-related quality of life. They show significant improvement in PPI discontinuation, about 74%, 59%, 72%, and 71%. And that appears to be durable. The longest trial data we have now is at 3 years and showed a 71% improvement in PPI discontinuation durable at 3 years. There are some special patient populations that are relevant to this. So standard TIF alone for your GERD patients. If there's a larger hiatal hernia, that needs to be repaired surgically with a laparoscopic hernia repair with fundoplication. It's also quite valuable in the Barrett's patients. Once you treat their Barrett's, assuming it has associated dysplasia, you can use this device to reduce the reflux. I won't go into some of these other niche applications, but to summarize, the GERD therapy gap is now being filled, particularly patients who don't want to undergo surgical procedures. Endoluminal approaches are now in a mature prime time position with durable, high quality evidence for multiple randomized controlled trials. And there's now additional clinical investigations underway in comparison to surgery. So if there's any questions, we'll take a couple of these now. Otherwise, we'll move right on to Dr. Karaja's presentation. So I don't see any questions on the portal just yet. So I think we'll actually there is one. What is the data on argon plasma coagulation in GERD? So APC is it does cause some scarring. It's less effective, at least in theory, than the anti-reflux mucosectomy, and we just don't have much data on it. I think it's almost certain that you need a more aggressive procedure to create a tightening effect. The anti-reflux mucosectomy, we have good evidence that you get a significant narrowing of the lower esophagus. So I think we'll go ahead and move on to Dr. Karaja's talk on obesity therapy. Mohammed, just make sure to unmute yourself. You're still muted there.
Can you see my slides?
Yes, we can, and we have audio now as well. So go ahead and go to full screen on your slides.
Can you see it full screen now?
Yes, perfect.
Okay. Yeah, thank you very much. Good evening. I'm going to start with the case presentation. It's a 48-year-old Emirati lady who was with BMI of 36, referred for weight management, had a medical history of migraine, asthma, and arthralgia attributed to fibromyalgia, and a surgical history of cesarean section, and she was not taking any regular medications. She had gradual weight gain over the years attributed by the patient to multiple pregnancies and COVID-related restrictions. She was having increasing problems with her sleep, with symptoms highly suggestive of obstructive sleep apnea, loud snoring, waking up with choking and disturbed sleep, and daytime tiredness and hypersomnolence. Actually, she remarked that she could nod off, fall asleep, even at work, and sometimes while talking to people. And she also complained of worsening arthralgia, and clearly her symptoms were impacting the quality of her life, and she has been advised to lose weight. So she tried many diets, and the maximum weight loss that she had was 5 kilograms, but she was unable to sustain the weight loss. She was seen in a bariatric surgery clinic, but she was not keen on bariatric surgery due to her fear of complications, and she was looking for less invasive options, and she expressed preference for intragastric balloon. So she had quite challenging social circumstances. She was going through an acrimonious divorce. She had 6 children, and she had full-time employment. And on top of all this, she was the carer for her mom, who had a stroke the year before. She had no GI symptoms, in particular no reflux symptoms. On examination, her BMI was 36. She had a short neck, remained unremarkable. And I must say that at this stage, I expressed some reservations about offering her a procedure due to her really challenging social situation and lack of support. But I sensed a real strength and determination and grit in this lady, was really determined to get back on track, but she needed some help, and I really wanted to help her. I think she was in a vicious circle. You know, the weight gain was causing problems with her sleep, and we know that sleep is increasing evidence that poor sleep or sleep hygiene plays a major role in the in pathophysiology of weight gain and obesity, and of course the weight gain was causing more sleep disturbance. So she needed really some way out of something to help her break the cycle. So I referred her to the psychologist and dietitian and to pulmonary clinic for sleep studies and consideration of CPAP. And her sleep study showed severe obstructive sleep apnea with apnea-hypopnea index of 42 per hour, desaturation up to 80% recorded. So she was actually cleared by the psychologist for the procedure, and the patient, remarked that she was well supported by her children. And on the 3rd of June, she underwent intragastric balloon, the SPAX adjustable 1-year balloon, and which was inflated to 450 cc. And she was given the usual sort of post-balloon medications to try and manage the symptoms, regular combination of PPI, antiemetics, antispasmodics, laxatives, and anxiolytics. And of course, she was well supported by the dietitian with written instruction and close follow-up after the balloon insertion. So 7 days post balloon insertion, her weight was down by 6 kilograms. It's about 7.5% total body weight loss. And she complained of recurrent epigastric pain, heartburn, and repeated vomiting. She mentioned that she was not tolerating even small drinks or oral medication. So I thought she was getting exhausted, and I offered admitting her for symptomatic management to give her a break as well. I thought her home situation was not really as well helping. She had a potassium 2.8, which was corrected, and she was discharged home after 2 days. 17 days post balloon insertion, I saw her in the clinic, and she was doing very well. Nausea had resolved, reflux symptoms were improving, and she was managing soft diet, and her weight was down by 10% at that stage, which is quite a lot. You must say that. I mean, you didn't really expect this rapid, weight loss, just over 2 weeks after insertion. So I was just a little bit concerned about this. She started walking 30 minutes per day, and she reported that her sleep was much improved, and the obstructive sleep apnea symptoms also were much improved. She reported more energy, and her joint symptoms were also improved. So 3 weeks after balloon insertion, that's 4 days after the previous review, she came to the clinic, and I was surprised to hear that she was really struggling. Had nausea, vomiting, and not keeping anything down, feeling weak. She lost 10 kilograms, 12.5% at this stage. On examination, she looked dehydrated. So I admitted her for IV fluids, PPI, and antiemetics. I was really surprised because, 4 days prior to this, she was doing, quite well. And it transpired that actually her mother had a further stroke and was admitted to hospital. And I think this was like the straw that broke the camel's back, So we thought we'll try adjusting the balloon down. We took some fluid out. This is one of the advantages of the adjustable intragastric balloon, but there was no improvement in her symptoms, and the balloon was eventually removed approximately 4 weeks after insertion. So she was reviewed in the clinic the next 4 months. Predictably, she gained some weight. Her weight was down at some point to 70 kilograms. After balloon insertion, she gained quickly to 4 kilograms, but she still maintained about 7.5% total body weight loss after balloon removal, and her symptoms she still had symptomatic benefits in terms of arthralgia, energy levels, and obstructive sleep apnea symptoms. And she was hoping to lose more weight with diet and exercise. She was making real efforts. Despite all this, her weight really didn't go down, and she was getting frustrated, and she expressed interest in having endoscopic sleeve gastroplasty. So at this stage, I was a little bit reluctant, because of her difficult social, situation. I referred her back to the psychologist, who reported that her psychosocial situation has improved. Her mother, I think, was admitted to a long-term care facility, and her divorce papers were coming through. So as she was looking, things were looking up for her. And she was cleared for this procedure. So she had endoscopic sleeve on the 30th of October, and she was admitted overnight after the procedure at her request for observation because of her sort of anxiety given the previous difficulties she's had with the intragastric balloon. And she had an eventful recovery and discharged home the following day. In fact, when I went to see her the following day, she had a big smile on her face, and she said, I should have, gone for this procedure right from the start. I can't believe, that she just was surprised how little symptoms she had after this procedure compared to the intragastric balloon. So 2 months after ESG, her weight was down by 10 kilograms at 13.3%. That's from after removing the balloon from 75 since the ESG, and her weight in total 16 kilograms, 20% total body weight loss since first appointment in the GI clinic. She's really delighted with the result and is aiming to get her BMI to within normal range. And we had a very nice thank you card from the patient and delicious dates. And the translation, of the card, is that to all members of GI team at SSMC, I was well supported and felt at home and not in hospital, as if I was with my family. Thank you for all the support and instructions. So it was a really very nice, card. It just emphasizes the point that the success of endobariatric program very much depends on teamwork, multidisciplinary team, approach, and who play a critical role in supporting the patient before and after the procedure. It's not just about, the procedure. It's about really providing comprehensive, obesity services, including the dietitian, psychologist, bariatric surgery, endocrinology, pulmonary specialist, of course, receptionist, all the GI staff, the endoscopy nursing staff, the coordinator. That's really, I wanted to take a picture, but unfortunately, because of the COVID-related restrictions, it's not something, I was able to do. Hopefully, I'll do that in the future. And you can see it's really a very large group of people involved in making this, happen. So I'm just going to go straight on giving you an overview of endobariatric procedure, really on intragastric balloon and ESG. So we all know that there are epidemic levels of obesity and diabetes in UAE with a huge economic and health burden. And we also know that bariatric surgery is very effective and leads to durable and meaningful weight loss compared to a standard of care. So why do we need more procedures? This is a study of 371 patients who qualified for bariatric surgery. So 284 of these patients were not interested, 3/4, in having bariatric surgery. And the reasons they quoted, the majority of them, is fear of complications or fear of dying from the procedure. And in fact, less than 2% of patients who qualify for bariatric surgery pursue bariatric surgery for these reasons. And we also know that medical therapy has a really modest efficacy and is limited by side effects, cost, and availability. These are actually the only 3 medications that are licensed for weight loss in Abu Dhabi. And the best, sort of the most efficacious medications is Saxenda, leading to only 5 kilograms, weight loss. So really, at best, has a modest effect. So there is a gap of unmet needs between medical therapy and surgical procedures, and endobariatric procedures help to fill the gap of unmet needs, especially for patients with mild to moderate obesity, and need to really have a change in paradigm, have a stepwise approach to obesity management. Now, intragastric balloons are space occupying devices that are placed in the stomach, and over the years there are a number of balloons that have become available and approved by the FDA after randomized controlled trials showed efficacy. There are fluid filled and gas filled balloons, and there are adjustable, non-adjustable balloons, and there are swallowable and endoscopically placed balloons. And the pivotal trials or level 1 evidence comparing these devices to sham or standard of care showed that the intragastric balloons lead to about 10% weight loss compared to sham or standard of care. And this is the swallowable ellipse intragastric balloon, which is gaining traction because it does not need endoscopy or anesthesia. So it is quite convenient, and The patient just swallows the capsule and it gets inflated to about 550, and after about 4 months, there's a special solution that will help dissolve the valve in the balloon, and the patient just will pass the balloon spontaneously, so that doesn't need endoscopy for removal. And it has been shown to be safe. There've been really no complications shown related to the passage of the balloon. And in a large registry of about almost 1,800 patients, the mean total body weight loss was 13.5 kilograms, and BMI reduction was 4.9. So it is really quite effective and convenient. And patients are expressing a preference, for this balloon due to its simplicity. So how did it work? Of course, apart from the fact that they occupy a space in the stomach, the level 1 evidence showed that fluid-filled intragastric balloon caused delay in gastric emptying, but almost 2 hours compared to air-filled balloons. And for this reason, the fluid-filled intragastric balloons are more effective than the air-filled balloons, lead to satiety and more weight loss. And in fact, for this reason as well, the baseline gastric emptying has been shown to predict response and tolerance. So if the patient has delayed gastric emptying before insertion of the balloon, this predicts poor tolerance to the balloon, and these patients should be offered an alternative procedure. So you actually, by utilizing this, you can reduce the rate of early removal from 12.5% to 4%. Now, this is the Department of Health obesity standard published in 2018, due to be reviewed this year, and intragastric balloons are on the list of procedures, approved bariatric procedures. But unfortunately, the same criteria is used as for bariatric surgery, which I think is not really appropriate. Need to have differentiation between intragastric balloons and bariatric surgery, I think, which is more suitable for patients with mild to moderate obesity, BMI between 30 to 40. And this is the recently published guidelines, AGA guidelines published in Gastroenterology, recommending intragastric balloon in patients who have failed the trial conventional weight loss strategy, with the proviso that it has to be combined with at least moderate to high intensity lifestyle modification interventions to maintain and augment the weight loss. And there are at least 4 randomized controlled trials showing that 60% of patients with intragastric balloon achieved 10% total body weight loss versus 13.7% for a standard of care over 6 to 8 month period. So next, I'm going to talk briefly about endoscopic sleeve gastroplasty, which basically is a minimally invasive endoscopic procedure that uses a commercially available suturing device to place full thickness sutures in the gastric wall to approximate the stomach walls, anterior and posterior stomach wall, so to reduce the size and to create effectively what would occur at a surgical sleeve gastrectomy, though without the need for surgery. Excuse me. So it was actually first published in 2013 by Dr. Abu Daya, the Mayo Clinic, who really helped pioneer this procedure, and who has been also instrumental in its training and proctoring our program at SSMC. And it's suitable for patients with BMI 30 to 40, and of course, also patients with higher BMI may be considered if they are not keen to have surgery. It's usually done under a GA takes approximately 60 to 75 minutes, and it's usually done as a day case procedure in the endoscopy unit. So, and there are several published systematic reviews and meta-analysis, and showed that the mean total body weight loss of 17% at 12 months, which is maintained at 2 years. And it shows a very low rate of serious adverse events. And similarly, this is a recently published consensus from Brazil showing similar results of 1,800 procedures with a percentage total body weight loss of 18% at 12 months and a very low rate of serious adverse events. And recommending the ideal BMI is 30 to 35 for this procedure. And actually, the weight loss, this is a study showing that the weight loss is durable. At 5-year follow-up after ESG, patient maintained the weight loss of 15%. And it has been shown to impact on comorbidities, HbA1c, measures of non-alcoholic fatty liver disease, and this has been compared to laparoscopic sleeve gastrectomy. And as you can see from this graph here, laparoscopic sleeve gastrectomy is more efficacious, leads to about 23% total body weight loss at 6 months, compared with 17% with ESG, but this is at the expense of more adverse events, and in particular gastroesophageal reflux disease, which is very low in patients with ESG. It can be as high as 15% with a laparoscopic sleeve. Furthermore, actually, when you stratify, when you break down patients to or look at patients with BMI of less than 40, there was no significant difference in the percentage total body weight loss at 12 months. So, in conclusion, endobariatric procedures help to fill the gap of unmet needs for patients with obesity, and patients are looking for less invasive procedures. The way I see it, that it is not here to replace, surgery, but really to complement the other modalities, and to give the patient more choice. Thank you for listening. I would be happy to take any questions.
Mohammed and Mustafa, you want to go ahead and come online, Mustafa, now open up your camera and microphone. We don't yet have any questions from the audience, but I do want to just initiate a couple of questions. Mohammed, these are obviously new, relatively new endoscopic interventions. I want to ask you a little bit about the learning curve for these.
Sorry, Mike, I lost you there, the microphone.
Muted, Mike.
Sorry, Mohammed. Thank you. We don't yet have any questions from the audience, but I wanted to ask a couple of questions just to get that started. Let's start with the learning curve. Do you want to describe a little bit about the training for sleeve, what we did here, and maybe what it's like to learn these, both for someone who's maybe done some suturing before, or from somebody who's just learning suturing from the beginning?
Yes, there's actually, thank you, Mike. There is some published data on this, and it is quite variable, the learning curve. So really the figure is anywhere between 7 procedures to 35 procedures. But as you said, very much depends on the endoscopist's previous experience with suturing devices, and to some extent on their previous experience doing advanced endoscopic procedures. So So I think what we did, at SSMC, we're very fortunate to have a partnership with the Mayo Clinic and have proctoring from Dr. Barham Abudaya, who came really to do the procedures to help with the training. So we did, he visited us 3 times. And we had patients for TIF and ESG, and we did the training with him, and I think we also, it was very helpful to have 2 people train because it can be quite intensive, and exhausting, to start with, until you get used to the sort of the technique, and we've recently have had the credentialing, and we started offering the procedure. In fact, we did our first patient about 10 days ago, and it went very well. And I saw her in the clinic last week, and she was really delighted with the outcome.
Good, yeah, thank you, Mohammed. And just to emphasize, it wasn't our first one, so to speak, is our first one after a long period of time training together and doing supervised cases with Dr.
Yes, Rotamont, yes, sorry, yeah.
There is an online question. Anonymous person posted, do patients meet with dietitians prior to surgery and begin their weight loss journey ahead of time, increase compliance and efficacy? Thank you. Maybe you want to even broaden that a little bit, the whole, what is the preoperative evaluation or pre-endoscopic evaluation of these patients?
Yes, actually, I start first of all by, the first visit they come to the clinic, I'd like to spend with the patient at least 40 minutes to take a detailed history. I think patient selection, this is really important, to identify factors that for success. Motivation, psychosocial background, patient selection is absolutely critical, for the success of the program. And of course, the evaluation by the members of the multidisciplinary team as well is critical, So explain to the patient the process, and also to manage their expectations. And then the patients they go through a mandatory period of assessment by the dietitian and a psychologist, and they may also need other assessments depending. For example, this patient needed to see the pulmonary physician and have a sleep study. Sometimes may get referred to the endocrinologist, and of course they need labs and some imaging as well, depending on what procedure they have. For example, if they're having a Intragastric balloon, now we started doing gastric emptying studies, which has been shown to predict poor tolerance if they have delayed gastric emptying, and so it helped with choosing the right procedure for the right patient. So after completing their mandatory period, then we'll see the patient, have further counseling, answer any questions that they may have. And then listen for the procedure. And after the procedure, then really it is critical that they have follow up with the dietitian, and also in the bariatric clinic, as I said, to make sure they are compliant with their dietary instructions. And we sort of also started incorporating, including the physical therapy. I think we've approached physical therapists recently to try and make this part of the program. So really it needs a holistic approach. And of course, to answer the question that the weight loss, we'll always emphasize to the patient that they don't have to wait for the procedure to start the weight loss, and they actually try and encourage them to start their journey, start to lose weight, because sometimes they think if they lose weight or BMI goes below 35 or a certain threshold, that this may exclude them. But I actually emphasize to them that that's not the case. It's the BMI at the beginning of their journey journey that will be considered, when we try and get approval, for from pre-authorization from insurance for the procedure.
Yeah, thank you. That's an observation as well, is that the key to success with these isn't really the technical performance of the procedure, although that's important. It's really this multidisciplinary approach. It's the patient meeting with the psychologist, meeting with the dietitian, meeting with the surgeon. We really like to encourage patients to know what all the options are. In the end of the day, if things don't go well, you never want to look back and say, well, they never met with the surgeon to know what surgical options they had. And that's it. One of the advantages of a large multidisciplinary team like we have here at SSMC, and many other centers have similar programs.
I absolutely agree with you 100%, Mike. I think it's really important that patient is fully informed and is aware of all the options, and is really, and I think for me as well, is as you said, it's not about the procedure. It's actually getting to know the patient. I mean, I really, I think this mandatory period is where you get to know the patient really well, build a relationship, with the patient, because it is a relationship that's going to last for a while. It's not just about open the procedure and off you go. So we, it's just a program, and we emphasize, this to the patient. Sometimes patients come in a hurry; they expecting, just to have the procedure, the following week, and sometimes they get really disappointed, So I think it's really important to manage their expectations. And I was going to mention something else, but it escaped my mind.
We have time for one last question, and then we're going to turn it over to, there's another Congress following this one immediately. But the question, maybe I can take this one, to enhance weight loss for patients who don't lose their desired weight. So this can fall into a few categories. One is the person who's had, for example, a Roux-Y gastric bypass, and maybe they lost weight and then they started to regain, or the patient who's had a sleeve and didn't lose the weight they planned. So for the post gastric bypass, there's a very effective procedure called a transoral outlet reduction by endoscopy, or TOR. We also perform that here at SSMC. Basically, you tighten up what has become a loose gastrojejunal anastomosis, and it's a combination of APC to achieve mucosal ablation, and then suturing, again, to reduce the diameter of the outlet. In fact, one of the 10 patients that we've treated now here, she did not lose weight after the first sleeve, and it looks like the distal nose suture may have broken loose, and we brought her back and enhanced that distal suture. And my understanding, she was one of your patients, what Dr. Barham did with us the first time.
Yes,
and,
that's right. Yes,
very effective weight loss after the redo.
Indeed, yes, I saw her recently actually, and she is really delighted now. She's lost more than 10%, since her redo, which is less than 2 months ago. So she's really delighted with the outcome. Yes.
And one final question, we just have 30 seconds or so. Any medications that you can use in conjunction with the sleeve or balloon?
Yes, I think this is the future, that we're really going to be looking at combination of these procedures, or combination procedure with medication. I think, unfortunately, we're limited by the fact that Saxenda is not covered by the insurance, but Saxenda has been studies showing that if you combine sleeve, for example, with Saxenda, it can lead to more effective, weight loss. So I think that's going to be the future. And there's a semaglutide is a drug which has been, hopefully become available maybe next year. UAE has been shown to be more even effective than Saxenda, and I think this also have a role to play, maybe in combination as well.
Well, we're going to wrap up here. It's just about 9 o'clock, and many of you also join the ACDS conference, which starts at 9 o'clock. So I want to congratulate Dr. Salam, Dr. Maki, who put on that congress. We'll be joining that ourselves here in just a moment. So please attend their conference as well. We do these together on Monday nights. Thank you all very much for your time. Thank you, Dr. Mustafa. Thank you, Dr. Mohammed, for a great presentation.
Yeah, thank you very much.
Thank you. Thank you.
Good night.